Hey, Bismillahirrahmanirrahim. Assalamu alaikum, everyone. Good evening, my colleagues, and thank you for joining us tonight. I'm Dr. Ibrahim Julaydan. I'm a consultant in advanced heart failure and transplant cardiology at the King Abdulaziz Medical City King Faisal Cardiac Center in the National Guard Health Affair in Jeddah. And it's my privilege today to join you in this session in behalf of the Saudi Heart Failure Working Group of the Saudi Heart Association. This is, I remind you all, a webinar with CME accreditation. So we are grateful for our sponsor today for the educational support and the scientific exchange that is made possible by our webinar. And before I begin introducing my guest, I will just talk a little bit in less than a minute about why we're talking about heart failure today. As all you know, it remains one of the most consequential cardiovascular syndrome in the kingdom, condition that intersect with a very high regional prevalence of comorbidities like diabetes, chronic kidney disease, hypertension, CED, given our data. Under the umbrella of the Saudi Heart Association and the Saudi Heart Working Group, we are trying to produce a statement paper, webinars, educational series to elevate the level, and hopefully we can manage those patients better and improve our outcome. And especially this topic, because for decades, heart failure with preserved or mild reduced ejection fraction was the orphan of the heart failure therapeutics. We did have a lot of negative trials in a long time and no much improvement into the outcome of the patient until there was a shift dramatically with the SGL2 inhibitor established across the LVEF right now, and with the new introduction of the non-steroidal MRAs, as Prof. Zanad will today explain to us and walk us through the evidence. It's my pleasure to introduce Prof. Zanad. Prof. Zanad is emeritus professor of therapeutic and cardiology at University de Royan and in Sarum, Nancy, France. He's also the chairman of the Cardiovascular Clinical Trialist Forum, arguably one of the most influential global platform shaping cardiovascular trial designer today. Dr. Had not just participate in writing a literature, but also he was one of the co-authors or a leading author of many of the heart failure trials that shaped our way of managing our heart failure patient today, from the earlier days of the FSS and the emphasis with the mineralocorticoid and antagonist and HFrEF, and with the newer data with the non-steroidal MRAs, either in the renal, cardiorenal metabolic space or the heart failure space. Beyond this, Prof. Zanad published and authored thousands of peer-reviewed publications. He was participating in a lot of the ASC heart failure guidelines and committee, mentored a lot of generation of heart failure investigators worldwide. So it's my pleasure and honor to present him today in our lecture, and the floor is yours, Prof. Zanad.
Thank you so much, Dr. Ibrahim. I'm really honored by your kind invitation, and thank you for the kind introduction. I am living in France, but I'm still pursuing a career internationally, and I wish you can attend one of the meetings I'm organizing in Washington every year in December called CVCT Cardiovascular Clinical Trialists. It's everything about trials in the cardiovascular field. My deep specialty is in heart failure and the intersection with clinical trials. And I'm so pleased to discuss with you today the evidence behind the novel therapies for ejection fraction, preserved ejection fraction heart failure. So definition is something very important, and very arbitrarily, we have decided that reduce ejection fraction below 40 and anything of moderately reduced or preserved is above 40. But at some point during my presentation, you will see that we really would like to lump all these together because many of the therapies which work across the large spectrum of ejection fraction. So I'm not going to be arguing much about the limits of ejection fraction, but let's see what defines most of the disease here is not necessarily ejection fraction. These are my disclosures. It's the prognosis. Now, the issue of HFrEF, it's much better known and the evidence is much larger, just because most of HFrEF used to have ischemic heart disease. And most of these patients are usually followed by the cardiologist, and they are known as cardiac patients before they develop heart failure, right? In HFpEF, most of patients are obese or cardiometabolic syndrome or elderly, not necessarily followed or known by their cardiologist for a cardiovascular disease. And therefore, they go under recognized. And the first diagnosis of HFpEF is sometimes missed because patient would go into death directly before they ever get to the hospital. And one important metric is the ratio between heart failure hospitalization and cardiovascular rates. In HFrEF, most of patients would have more frequent hospitalization than cardiovascular death. In HFpEF epidemiology, we have a much higher rate of death because most patients go under-recognized and go into their disease directly by dying, not necessarily diagnosed during heart failure admission. So this slide shows you indeed the rising incidence because it's a rising recognition of this disease. There are fewer and fewer HFrEF because the better management of acute myocardial infarction and more HFpEF, right? And this is related to the aging population, but also, and I'll come to that later, to the obesity epidemics. Now, this disease is very poor and it is equally severe to HFrEF. Again, this is very much under-recognized. Patients die and get hospitalized as frequently as in HFrEF. And you can see it here in the both slides here on the middle and the right-hand side. Now, one way to look at the what we call the residual risk is in clinical trials. Clinical trials is the best word and best case scenario because it's much better outcome that in real life in epidemiology because these patients are usually having a good background therapy, they have better follow-on. And what you can see here is the latest HFpEF trial, Emperor Preserved and Deliver. And in these HFpEF trials, patients were taking the best possible treatment at that time. And you can see over 3 years of follow-up, 36 months, what we call the residual risk. Despite treatment and despite the SGLT2 inhibitor, you can see that there is almost 15% of the patient, 1 out of 6 patients, who would develop a hospitalization for heart failure or die from a cardiovascular cause. These are the main outcomes in heart failure trials. And this is better depicted in this slide. In 100 patients, you can see if you let them with the best possible treatment, this is in a trial condition. You can see the treatment here, RAS inhibitors, MRAs, beta blockers. 1 out of 5 of these patients will either not survive or get to the hospital within 3 years of follow-up. So that's a really serious condition. Now, we have started addressing this condition in the late 80s with a number of trials, but mostly with the highly statistically significant results. And while at the HFrEF, we had plenty of medication with a large body of evidence and plenty of recommendation in the guidelines of the level 1A, in HFpEF, I leave this slide intentionally blank because we didn't have until very late any hard evidence. And these are the major trials, historical trials, with an ARB, which is charm preserved, with an ACE inhibitor, with perindopril, the PepCHF, and another ARB, irbesartan with I preserve. And you can see that most of them have been neutral. Well, we can argue, and have been lots of sub-analyses, post-hoc analyses showing that these drugs may still work, but the level of evidence is not very high. And then came TopCat with spironolactone, and I'll come to the story of TopCat later because it needs a specific focus. But overall, the trial was also neutral, except that in some condition we can see that spironolactone may still be effective. I can get to that later. And this is indeed what happened in TopCat. On the right-hand side, we have splitted the all population in the trial into patients recruited in the Americas and patients recruited in Russia and Georgia. And you can see the huge gap in outcomes. The patient recruited in Russia and Georgia have one-fifth of the event rate than patient in the Americas. And it is simply that these investigators in this country has cheated and they didn't enroll patients with real heart failure. And if you get to patient with real heart failure because they have been admitted for history of heart failure or they have high NT-proBNP, the trial was positive and spironolactone indeed works in HFpEF. But admittedly, this is not the highest possible level of evidence because this is post hoc and subgroup analysis. And the key subgroup I would like to really share with you here, it's a publication we have made almost 10 years ago from the TopCat data. Patient, in order to be enrolled in TopCat, they had to have either a history of heart failure hospitalization, which it's easy to cheat. In some sites, the investigators decided that the patient have had a history of heart failure hospitalization. They ticked the box, not ascertaining that patient did indeed get to the hospital for heart failure. Now, in the alternative condition to enter the trial is to have a high NT-proBNP, and this is what you can see on the bottom here. Almost 1,000 patients were enrolled on the basis of high NT-proBNP, and this you cannot trick. And you can see on the right-hand side, the trial was positive. So patients with real HFpEF have a 35% decrease in the primary outcome of cardiovascular death and heart failure hospitalization. So spironolactone is most likely effective, although again, this is subgroup analysis with all the limitation of subgroup analysis. Now, let's move on with the most recent trials in HFpEF. And I have been the privilege being a co-PI of the trial with Emperor empagliflozin, being involved in the steering committee of Paragon and Fine Arts. So I'm really pleased to share with you results of the latest trials in this domain. Let's start with Paragon heart failure, which is sacubitril valsartan. You are very familiar with Paradigm, the trial upon which is based the use of this medication in HFrEF. In HFpEF, the trial was Paragon, and again comparing sacubitril valsartan to valsartan alone. And the trial was marginally statistically significant because the p-value was 0.059. But again, p-value is not so important because this was indeed 13% decline in the outcome. And if you look at the data differently, this means you look at the events as decided and adjudicated by the investigators, and you look at different outcomes, you can see that the totality of evidence shows that sacubitril valsartan is likely beneficial in patients with HFpEF, and it has been accepted by the FDA, and it has received a 2A level of evidence in HFpEF. Now let's move on to SGLT2 inhibitors. And you know that there have been two trials, one with dapagliflozin, the other with apagliflozin, essentially very, very reproducible. We call it externality. If you have not one but two trials with two similar drugs in the same condition, both are positive. This enhances the level of evidence, and this is the reason the recommendation with this class got the level of evidence A and the strength of recommendation 1. Two trials, not a single trial. And now, if you look at the data differently from SGLT2 inhibitor, this is with dapagliflozin, but it applies exactly the same with empagliflozin. And you try to measure what are the lifetime benefits associated with the medication in patients with HFpEF. You can see here that the mean event-free survival time is prolonged by 2 years in a typical patient who has been initiated on dapagliflozin. So if you initiate a patient on dapagliflozin, you are giving the patient a gift of 2 years event-free, no hospitalization, no death. That's really sizable benefit. These slides show you the evidence so far before Emperor, and you can see the size of benefit with SGLT2 inhibitor as compared with the other HFpEF trial, and therefore Emperor Preserved was the first compelling trial in HFpEF showing the evidence of empagliflozin, and dapagliflozin with the liver show the same results. And therefore, the recommendation will have to be improved. These are the recommendation of 2024. We are still expecting the recommendation of 2026, but 2024, SGLT2 inhibitor got to class 1 in HFrEF and in HFpEF. So this is really foundational therapy across all ejection fraction, and this is important. Uh, Not to split necessarily heart failure in REF and PAF, because we have evidence now with some drugs that the benefit is equal across all ejection fractions. So let's move on to another very important class of medication, which is mineralocorticoid receptor antagonist, MR antagonist. You are familiar with the RALS trial with eplerenone in HFrEF, and I have shared with you the data with TopCat in HFpEF. Now, we have a new class of non-steroidal MRA, which is finerenone, but all based on the same conceptual framework that aldosterone is bad for you. It's bad for your patient, and it's not only excess production of aldosterone in heart failure, but although even with normal aldosterone levels, the receptors, MR receptors, are overexpressed and overactivated in heart failure, and therefore this produces inflammation and remodeling and fibrosis, which will produce a decline in ejection fraction or thickening of the heart and the substratum of creating sudden death and arrhythmias. On this basis, MRA were developed to treat heart failure, including in heart failure with preserved ejection fraction. But you know that this MR activation occurs also in the kidney, and therefore we had the historical background of finerenone with the Fidelio and Figaro trials in CKD patient with no heart failure. And we have shown that in CKD with diabetes, patients progress much less to heart failure when they are exposed to finerenone. So we had already as a background, before we got to have PAF trial, we have already as a background that finerenone prevents heart failure in patients with CKD and diabetes. Now, this has initiated a huge development with many newer mineralocorticoid receptor antagonists, and these are but a few which are under development. I will be focusing on the most mature of them, which is finerenone. These slides show you the totality of evidence we are having with all MRA trials in HFrEF on the left-hand side, on HFmrEF and HFpEF on the right-hand side. And my focus today is on fine arts with finerenone in HFpEF. I have also already shared the data of TopCat, and the other trials are still pending. So this is fine art. Fine arts essentially expose patients with HFpEF to finerenone or matching placebo with a dose varying across eGFR. If a patient had eGFR below 60, they got to a maximal dose of 20 milligram. That's very important. And if patient had a normal eGFR, then they could be uptitrated up to 40 milligram. So you need to keep that in mind in order to adjust the dose depending on eGFR. And these patients were randomized short after hospitalization. And you can see that many of the patients have been hospitalized within 7 days after discharge from heart failure hospitalization. This has become a usual trick in order to increase the event rate. So we are capturing what we call the vulnerable phase in patients short after discharge, but still half of the patients were discharged more than 3 months before randomization. So we have a wide spectrum of patients, short and remote from a recent heart failure hospitalization. And you can see on the right-hand side, 35% of patients were taken in RB, not so many were taken on NARNI at that time, and then so many were taken in SGLT2 inhibitor, almost 13%. And the main result, you may be familiar with that already, a very significant decrease in the outcome of CV death and heart failure hospitalization of 16%, highly statistical difference. And you can see the composite of these, the components, I'm sorry, of the composite endpoint showed that the benefit was mainly driven by prevention of heart failure readmission. CV death was not much affected, as you can see here in the Kaplan-Meier. You can see in the left-hand side the primary endpoint of the composite endpoint, statistically significant. CV death and all-cause death were not much affected. So the benefit was most focused on prevention of heart failure readmission. The safety was very much as expected. You know that with MRAs, you need to watch out for blood pressure, and indeed there have been slightly more hypotension with finerenone, although this was not statistically significant. And you need to watch out for potassium, and as expected, there was a doubling of the rate of hyperkalemia, but still nothing serious and no adverse event, no excess hospitalization related to hyperkalemia, and no excess death related to hyperkalemia. But hyperkalemia is here to stay with MRAs, and you need really to monitor patient and adapt the dose. And on the other hand side, on the other hand, you can see that there were much fewer drop in potassium hypokalemia because these are essentially medication which are potassium sparing, and the effect on prevention of drop of potassium is very important because this is behind the benefit on sudden cardiac death. So there is no pain, no gain. You can win on fewer hypokalemia, but then you need to watch out for the risk of hyperkalemia. Now, we have looked at the patient receiving SGLT2 inhibitors in this trial, and there weren't many of them. And you can see that some of the patients got initiated an SGLT2 inhibitor, fewer when the patient were on finerenone because they are doing well. But overall, there was a kind of synergism. If patients have a chance to receive an SGLT2 inhibitor plus finerenone, the benefit is enhanced. So the benefit is additional. And therefore, the recommendation is indeed to combine the medication. And you know that we will already have fixed dose combination of an SGLT2 inhibitor and finerenone. Now, again, the same type of analysis of how much you are offering to your patient if you have them exposed to both medication together, and you can see that you can increase the event-free survival by 5 to 6 years, and the survival itself in a patient aged 65 years of age. If you get the patient to receive both medication, you are giving to the patient a gift of prolonging her or his life of 3.5 years. That's really spectacular. There aren't so many medications out there which can offer this kind of benefit in such an elderly population. Now, we looked at the benefit and how early the benefit is visible. This is a statistical analysis screening across the follow-up, and you can see on the right-hand side that the first analysis at 30 days, just 1 month after initiation, was already statistically significant. And if any, the curves kept diverging. On the left-hand side, another type of analysis, we call this blind analysis, showing again that on average, the difference was reached statistical significance at 1 month. This means you need not wait. As soon as the diagnosis is there, you need to get your patient initiated on therapy immediately because the benefit may be visible as soon as a month after initiation of treatment. Now, we have looked at all sorts of subgroups, and the benefit was very significant across all kinds of subgroups. We looked also at the risk categories and how much the benefit is consistent across risk categories. And you can see that there was no statistically significant interaction. This means that the medication was effective across all risk categories, although on the right-hand side, it may appear that the higher the risk, the higher the benefit, which is, intuitive. Now, we also have looked at other outcomes. I don't have with me the slide on atrial fibrillation, but we have seen in other MRA trials, like with the emphasis trial, that MRA can predict new onset atrial fibrillation because of the remodeling, especially in the atria, antifibrotic effect. In this slide, we have looked at the new onset diabetes. Well, you know that this medication is a great medication in patients with diabetes and CKD from Fidelio and Figaro, with prevention of further decline in renal function. But in this heart failure patient, we have been also able to show that patients without diabetes would progress less to diabetes, so new onset diabetes was prevented using early enough this medication. So this additional benefit. Now, of course, as I said earlier, no pain, no gain. This means there are some side effects, and you need to be careful with the dose optimization. And this slide is a kind of sophisticated slide and show you the distribution of eGFR, renal function. And you can see that the further left you go, the higher the incidence of hyperkalemia. The left is patient with poor eGFR, eGFR below 45. And you can see that below 30, now the benefit to risk ratio is less because you have a higher rate of discontinuation, higher rate of hyperkalemia, but still the efficacy is still there. And therefore, there is no reason to deprive patients, even with low eGFR, from this medication because these patients are at higher absolute risk. And therefore, the absolute benefit is higher. And still, the balance of benefit to risk is favorable in this patient. You just need to decrease the dose, use half a dose, monitor potassium more frequently, and adapt the dose consequently and prevent hyperkalemia with the beta potassium monitoring, preventing potassium diet, and eventually using potassium binders. So you need not deprive your patient from this life-saving medication just because of the excess concern about hyperkalemia. Now, in order to get you the full picture of MRAs, this slide shows you the HFrEF and HFpEF trials. And it is my personal take that this class of drug is potentially consistently effective in HFrEF and HFpEF, although we don't have a very solid HFpEF trial with spironolactone or eplerenone, and we don't have we don't have evidence at all with finerenone in HFrEF, right? But across the totality of evidence, as I said, across this class altogether, we do have consistent benefit across different categories of ejection fraction. And we have done this meta-analysis. We have published a couple of years ago showing that the benefit is highest in HFrEF with MRAs, and the benefit is still solid and robust in HFpEF, but overall the class is effective across all ejection fraction. But now getting back and focus on HFpEF, these are now not one, but two foundational therapy, SGLT2 inhibitors and non-steroidal MRAs, and it is quite likely that in the future guidelines, we will have this medication upgraded to class 1A, probably recommendation. We have looked at safety, and I have already mentioned the issue of potassium, but this also shows you the benefit across large number of the ejection fraction, going all the way from 40 to 75%, but likely also even below 40%, but we don't have strong evidence so far, and there is ongoing trial with finerenone in HFrEF, and the evidence will be hopefully complemented in a couple of years. Now, this is the trialist perspective. I am more than happy to having had the chance to share with you the results that we have of the trial we have run. Now, my biggest frustration as a trialist is to provide evidence which is not acted upon and which is not implemented. One major challenge is to get our patients to receive evidence-based heart failure therapy. And you know that very few patients are receiving triple or quadruple therapy. And this is a bigger frustration. One of the reasons in HFpEF is that we have gone multiple ways in order to make this simple disease appear very complex. The slides show you the different ways to phenotype patient with HFpEF. And we have tried to create multiple subgroups depending on comorbidities, depending on echocardiographic feature, depending on proteomic analysis. All of this is loss of time. And you can see the diagnostic process has been made very complex, and therefore we really need to make things simpler. And this is the simplest possible slide. Ejection fraction all the way from 15 to 75. And you can see now we have medication active across all ejection fraction. So I may not have entitled my talk HFpEF. I should have only addressed heart failure in general. You can see on the left-hand side, DAPA, HF, and deliver combined together. The FXU of dapagliflozin very consistent from 15 to 75. Empagliflozin, same thing. And I would focus on the MRAs, and you can see it's only at the very highest end of ejection fraction that there may be some loss of benefit, but over the full spectrum, there is a consistent benefit. Now, the very important focus of the future is going to be obesity. HFpEF is the disease of the obese patient. If not necessarily overweight, it's visceral obesity, which is better measured by waist to height ratio. And this visceral obesity, this visceral fat, is full of adipokine. Adipokine are a huge number of hormones produced by the adipocyte, and one of them is, by the way, aldosterone. So aldosterone is not only produced over the kidney, but it's also produced in multiple tissues, including in visceral fat. And this adipokine hypothesis shows that actually most of HFpEF patient, if you measure waist to hip circumference, you will find almost 70, 80, 90% of your HFpEF patient have visceral obesity. And this visceral obesity is behind this inflammation, especially the epicardial fat, which drives the cardiac fibrosis, inflammation, and progression to HFpEF. And as such, medication which help losing weight, like GLP-1 receptor agonist, or GIP, this medication has been shown indeed to prevent cardiovascular death and heart failure hospitalization. And there are heart failure dedicated trials ongoing. One of them is a small trial, the Summit trial, with tirzepatide, and which shows that this is a very potent medication on preventing time to first event to cardiovascular death or heart failure hospitalization. So loss of weight and mitigation of visceral obesity may be the future milestone in treatment of HFpEF. Now, my two final slides are going to be focusing on how a good job we can do if we really treat our patient aggressively, high intensity care. This concept of high intensity care was developed in the Strong HF trial, which actually enrolled patients all across ejection fraction, half RAF and half BAF. It was borrowed from oncology. Oncologists, whenever they do a diagnosis of a cancer, they wouldn't care by the stepped approach, by start low and go slow, by combining medication step by step. They will give your patient the maximum massive therapy. They will eventually pedal back if there are safety issues, but they will immediately start with the high intensity care. And this was the concept which was tested in Strong HF, whereby patient short after discharge and actually before they got discharged, they were loaded with all guideline directed medical therapy, very quickly up titrated within less than a month after discharge. And you can see the high intensity care, the red curves, produced a much better benefit than the usual care. So a key element here is do the best possible treatment as early as possible in all your patients. And this is again the type of slide and curve I like to show. I have shown it twice. Now I'm showing it third time with these lifetime benefits. If you use comprehensive medication, all medication at once, and you can see in patients with ejection fraction below 60%, age 65 years of age, you can give a gift to your patient of 5 full year survival, 5 full year, as compared to patient who was not in treatment. So this is really substantial, very strong evidence, a very substantial benefit. Thank you so much for your attention, and I wish you can have some questions so that we may have a chance to discuss the data I have shown with you. Thank you so much.
Thank you so much, Prof. Zanad. Excellent lecture as usual with extensive review of the evidence and evidence from before, all the previous trials, and also the argument behind probably treating all type of heart failure the same, simplifying things for us. So for the attendee, we have more than 300 attendee in the room. It's a very great number that we're always having in our heart failure working group webinars. So please, if you have any question, type it in the Q&A box. While you start typing, I will maybe kick off with a question that's always in my mind, Professor Nad, if you don't mind, about especially you are participating a lot in the steering committees of the trial about the primary endpoint for those patients. So I'm noticing that we always do the heart failure hospitalization or worsening heart failure event with cardiovascular death. And it's always the same, like as it's a copy paste, we find the heart failure hospitalization driving the benefit with negative CV death signal. Is it because probably we're not doing long enough trial in those population that they do die later on because of other issues? So should we think about, for example, combining cardiac and renal outcome or cardio-renal metabolic outcome like weight loss, renal preservation, because those are probably will cause, I'm not sure, maybe will the data will be more prominent and people will be more encouraged to start those medications. So what do you think about this?
Well, this makes a whole lot of sense. Actually, the all the area is driven by regulatory, guidance. The FDA mandates that for approving a drug in heart failure, you need to show a benefit on the combined endpoint of CV and heart failure hospitalization, and that's the reason everyone is focused on that. But it makes lots of sense because these patients do not only suffer from heart failure, they do suffer from decline of renal function, for example, and they can go in complication, renal complications. And by the way, in HFpEF, patient with obesity, they do suffer from liver as well, from MASH and MASLD and liver fibrosis, which is consubstantial with the other diseases. The same causes producing multiple effects on the kidney, liver, and the heart. So it makes sense, and we have been advocating this for a while, to have a component with the heart, the kidney, and including the liver. This is what we call the healthy lifespan concept. And therefore, you'd like really to prolong healthy lifespan, the patient not dying and not having any one of the complication of heart failure, whether it is CKD, heart failure hospitalization, or MASLs. The future will tell us whether we will be powerful enough to in order to influence the guidances. But holistically and pragmatically, you are absolutely right.
Excellent, Professor Naz. So, one question from the audience. They're asking, thank you for this great presentation and asking about obesity-induced HFpEF and is it can convert after time if not treated to HFrEF? I think it's a complex question a little bit.
Well, not so complex, and the question is really important because the contribution of obesity is absolutely not the same in HFpEF and HFrEF, right? Of course, obesity is all across, and obesity may contribute to HFrEF through coronary complication. Patients need to have a myocardial infarction, and they can progress in HFrEF, but without any previous cardiovascular event, right? Patient with obesity because of the cardiorenal metabolism complication, they can go straight ahead in half bath. And therefore, weight loss, and by the way, bariatric surgery is the best treatment to prevent heart failure altogether, preventing it, right? So weight loss medication will certainly do be very effective in preventing heart failure, but HFrEF do have this and one important issue which has been resolved recently is in HFrEF, there is this notion of obesity paradox. Some people may have heard about it. If you have a high, uh, uh, BMI, you may be protected, and the BNP levels would be lower. Um, while the BNP lower is nothing to do with obesity, is just because the adipocyte degrade BNP at a higher rate. And very recently, with some genetic studies of Mendelian randomization led in UK Biobank, they have shown that there is no obesity paradox, and the higher the BMI, the higher the risk across all ejection fractions.
Excellent. The other question, Abdul Hakim is asking about MRA. Did Fineron give additional benefit more than spironolactone? Because in his opinion, he think based on the cost, there is no big difference. So I think that's probably the difference between the top cat not positive versus the newer data. So what do you think, doctor?
Well, I wish I could answer this question, and I have been advocating for a head-to-head comparison for a while. We will not know until we have a trial comparing spironolactone and finerenone. The level of evidence is very compelling with finerenone because we do have a trial positive, no arguing. In TopCat, there is some evidence. I'm confident that spironolactone is likely effective. And again, I don't want to throw spironolactone altogether because in many countries, people may not be able to afford finerenone. And if you cannot afford finerenone, I'd rather have your patient on spironolactone than on nothing, right? But if you can, you have a much better evidence with finerenone, and that's the way to go.
Excellent. I think that's a very relevant question because of the cost and the access to the medication, different areas. So having a positive data with MRAs overall, as you mentioned, with all the meta-analysis, encourage us if we don't have an access, not just to stop with those patients, but to try give them the benefit of the medication. Even I can argue with that with the RAS inhibition in general in MREF, for example, or the lower group of HFpEF, because as you know, sacubitril valsartan still an expensive medication compared to the other group of medication for those people.
You're right.
Okay, Dr. Fahd Al is asking, thanks for the great lecture. Can you give us a simple definition for HFpEF for non-cardiologists as those patients usually followed by non-cardiologists? I think that's probably go to the same point that you're discussing about how we're making things complex a little bit, preventing good therapy from the patient.
I didn't get the question. Can you repeat that, please?
Yeah, so Dr. Fahd is asking, can you give us simple definition for HFpEF for non-cardiologists as those patients usually
Oh,
followed by non-cardiologist?
Well, I love this question. Um, Before we get the positive trials in HFpEF, there have been a huge fight about how to define HFpEF. And the pathologists, why we call them the diastologists, have gone multiple ways in order to make things very complex, based in echocardiography and saying you can diagnose the medication, the disease only if you get the exercise patient in order to see the pressure volume loop. Now, the very simple definition is a patient with heart failure symptoms which may improve after initiation of diuretics. That's simple. You don't need to get to the cardiologist. If you have a patient, well, with risk because they have CKD, diabetes, or obesity, whatever, and they're symptomatic because they are breathless, they have edema, whatever, get them first on diuretic, and the patient improve, then this is likely to be heart failure. And then you will have ample time to get the patient to a cardiologist, do an ejection fraction, but do not wait. Of course, depends on the countries. I don't know what is the situation in your country, but in France, you may wait 1 or 2 months before you get an appointment with the cardiologist. Okay, you may wait 3 to 6 months before you can get echocardiogram. And this is lost time. You need not wait. You can get started as soon as possible.
Excellent, Prof. So another question from Amnil Khaldi asking about, I think you mentioned that in the lecture, but maybe you can re-emphasize for patient with HFrEF, would you prioritize spironolactone, eplerenone versus finerenone, and why?
I'm a clinical trialist, so I believe on the evidence, right? Conceptually, I can tell you, yes, potentially there is a reason to believe there is a class effect, but this is conceptual, right? We do have the data in half-pref with the eplerenone spironolactone. We do have the data in half-pref with finerenone. And if you can afford this medication, go for them in their respective indication, right? Now, unfortunately, we didn't have, head-to-head comparison, and we wish at some point we'll have the head-to-head comparison in the future. You're, you're on mute, Dr. Ibrahim.
Yeah, sorry about that. A question for me while waiting for more question from the people is the potassium issue and the renal failure issue. So we do have a big population of diabetes, chronic kidney disease in those population in Saudi, and we do face hyperkalemia a lot. We do have now, thankfully, for the HFrEF population, the potassium binder. I don't think we have the same probably evidence in the HFmref and HFpEF, and now probably the need will come with the introduction of such therapy such as finerenone that will change the outcome for those patients. So can we advocate at this stage to start potassium binder in those patients that will struggle with hyperkalemia, or we still, or do we need theoretically as trial looking for those population specific?
Well, I don't believe we need trials. We have evidence that potassium binder may maintain potassium, but where best you can use them, well, I would not use them in all cases of hyperkalemia because most of hyperkalemia are preventable. They are manageable with dose mitigation, right? It's only in patients with recurrent hyperkalemia. I call them the frequent flyers. You have done all your best work in order to instruct them about diet. And I know in your country you eat lots of dates, for example. So you need to be very careful with it. You have done everything possible with, adapting the dose, but still the patient is coming back with high potassium. In that case, yes, you can start the patient on potassium binder rather than stop the Finero or the MRA altogether, because this is very counterproductive. These patients are at highest needs of continuing medication.
Excellent, Prof. We have a question from Dr. Osama Al-Muqbil. He's one of our heart failure colleague in Saudi also. Amazing lecture and great discussion. He's asking about how comfortable are you giving SGLT2 inhibitor and non-steroidal MRA in patient with GFR less than 20?
Well, not very comfortable in patient less than 20. I would say the evidence is low because there aren't so many patients who have been enrolled with EGFR below 30, by the way. So below 15, no evidence, and some evidence of harm. Below 30, well, depending on the situation, if the patient is really severe and you need this medication, you need to be very careful with potassium and declining eGFR because these patients are at high, they have, though they try them. SGLT are fine because of potassium, and there may be some benefit in these patients, especially if they are really symptomatic.
Okay, I'm not sure if it was only me, but probably the last probably 30 seconds was a little bit disconnected, Professor Nat. So do you mind just repeating the last part of patient with the renal
Oh,
GFR?
I'm sorry. Yes, I say that. Yeah, uh, I I would be careful with EGFR below 30. By the way, even more so MRA. With the SGLT2 inhibitors, but below 30, we have substantial number and the drug works well. With an MRA, we are exposed to high risk of worsened renal function and of hyperkalemia. But again, as I've said, if the patient really symptomatic at high cardiovascular risk, I may still try to get a low dose with a very close monitoring of potassium and renal function.
Okay. Another question by Abdul Hakim, thanking us for for the information, asking about related to HFpEF driven by obesity. So phenotypic obese HFpEF patient, is it RNA needed because it seems in RCT is neutral outcome? I think if we change our mind on change to think about phenotype treatment, what do you think about that?
Well, most HFpEF patients are obese. So, and again, the importance is not body mass index, it's visceral obesity. So you better measure waist circumference or image patient in order to find out because the evidence is that these medications work across circumvented valsartan may still be beneficial, but as I've shown in one of my slides, the magnitude of benefit is much lower with Paragon in Paragon than in fine arts. So I would insist to having a Fineron. If the patient is still symptomatic, I will certainly try, circumvented valsartan.
Okay, Prof. So question for me, like we now have the four pillars in HFrEF as we always discuss in meetings. Um, I have a thinking in my mind. If we think right now with the more evidence, should we have a new four pillars for MREF and HFpEF with the introduction of non-steroidal MRA, maybe GLP-1 and RAS inhibition, or we're probably gonna complicate things and make it a treatment across the four pillars, across the whole spectrum? Like, are we gonna be able to? Is it better to specify or better to make it universal? For the point that you mentioned, that most of the patients are lacking access to the medication, people are not prescribing because we make it complex a little bit all the time.
Yeah, well, that's the huge challenge of heart failure specialists is getting the huge evidence we have been producing. Well, actually, we have been extremely effective in producing a high level of evidence with heart failure medication, but we have neglected the implementation phase. Therefore, we are, you know, coming up with more and more medication, more and more efficacious, not caring about how much this is applied on real life. So real life is really very important. And we may need to get into implementation trials like the Strong HF trial, for example, which are strategy trials, and look at how best we can achieve optimal guideline medical therapy, how quick, in order to speed up titration and get our patient the sooner the better, full steam on all medications together because the evidence is there, but implementation is complex, right? People are concerned about safety. People are concerned about the cost. People are concerned with polypill, etc. And we have neglected this. We need to take all this behavioral science, right? How much a patient can swallow, how many pills they can swallow, how much monitoring we can do. So we need to get into this phase of strong HF type of trials in order to make it easier. And we are getting there with the polypill. Soon we'll have in a single pill two, maybe three medication in the future, and this will probably make life easier for many patients.
Excellent. I like that we have a lot of questions for non-cardiologists because they are probably facing a lot of our patients. So this non-cardiologist asking, what class would you start in a HFF patient up to the current evidence as a summary? So probably like a couple of summary point for patient for non-cardiologists. If you see a HFpEF, what is the strongest evidence that we
Well, you need really to take care because HFpEF is uh, growing. So you need to pay attention. And again, for the non-cardiologist, you need to pay attention to the symptoms and not necessarily decide that patients are breathless just because they are not exercising or having a poor lifestyle or putting up, weight and obese. They may have already had PAF, right? And again, if you had a chance to look at the echocardiogram, that's fine. Otherwise, get them on medication and certainly start with diuretic and all these medication. And now the good news is they are safe and well tolerated, and therefore you can get them tried on this medication. Um, but you need to face it. I mean, many of these patients were neglected just because we thought they don't exercise, they are putting up weight, and therefore many of them are women, they are aging, and then let them alone. But that we know that they are at high risk of dying, they are at high risk of getting to the hospital. Then get them started on medication as soon as you can.
Excellent, Prof. Zanad. It was a pleasure having you today, discussing this important topic, educating hopefully a lot of physicians, cardiologists, non-cardiologists, more than 300 people attending in managing this complex patient with cardiac involvement, renal metabolic, kidney disease, liver disease, which is a very high prevalence in our community. So this is very relevant to our community. So on behalf of the Saudi Heart Failure Working Group, I thank you very much. I thank all the attendees. All the CME hours are automatic for people who registered with the email that they are logging in with. And hopefully we see you for a future webinar. And hopefully, Prof. Zanad, we see you here in person, inshallah, in Saudi Arabia.
Inshallah. Thank you so much. Thank you. Have a
Thank you
great
so
day.
much, everyone.
Bye.
Thank you very much.